This is Chapter 19 of Wilkins, Periodontal Disease Development. It should take about 45 minutes to go through the slides in the chapter. We've talked a lot about the periodontal support system in other chapters. You know all about the periodontal ligaments and what they do. The periodontal disease, as we said in previous chapters also, is an infectious communicable disease that's initiated by microorganisms in the dental biofilm that actually collects on the teeth when oral self-care is inadequate. So review the terminology on the chapter that's in table or box 19-1. We do have learning objectives, which we don't need to go over, but they are there. And we'll just dive right in about the periodontal-systemic disease connection. There's a lot of talk about the immune host response and the oral systemic link. So there's been a lot of research in this area on the association between periodontal infections and a variety of systemic diseases and conditions. That include cardiovascular disease, adverse pregnancy outcomes, respiratory disease, chronic kidney disease, rheumatoid arthritis, obesity, cognitive impairment, osteoporosis. And despite the association, periodontal disease has not been shown to cause systemic disease. But the mechanism for the association still isn't clear. But the infection and or inflammation are common elements of all the diseases and conditions. So the association between periodontal infection and various systemic diseases and conditions makes it critical for early identification and treatment as well as management of periodontal diseases or infections by us, the dental hygiene professionals. This is a picture that shows clinical changes in periodontitis. Now, periodontitis, as you know, is characterized by inflammation within the supporting tissues of the teeth and progressive destruction of the periodontal ligament and loss of supporting alveolar bone. So it's the apical migration of the junctional epithelium and the attachment apparatus. Let's talk a little bit about risk assessment. There are different factors that are involved, and complicating and risk factors for disease development can be etiological, predisposing, or contributing. And they're delineated as follows. So for etiological factor, it's the actual cause of the disease or condition. Predisposing factors renders the person susceptible to a disease or condition. Rather, the contributing factor lends assistance to or supplements or adds to a condition or disease. Then we've got risk factor, and that increases the probability that disease will occur. Etiological, predisposing, and contributing factors may be local or systemic. So a local factor is a factor that is in the immediate environment of the oral cavity, or specifically in the environment of the teeth and periodontium, versus a systemic factor is a factor that results from or is influenced by a general physical, mental disease or condition. So we've got risk assessment tools, and risk assessment identifies the level of likelihood for developing periodontal disease and is really an integral part of individualizing a preventive strategy for periodontal treatment. Risk assessment may reduce the need for more advanced periodontal therapy, as well as improve patient outcomes to reduce oral health care costs. So examples of periodontal risk assessments, or PRAs as they're called, are various tools. There's a periodontal risk calculator, a PRC. That's a web-based risk assessment tool that uses known factors such as smoking, diagnosis of diabetes, family history or pre-existing periodontal history, and status to predict the risk for periodontal disease. and there has been shown to be a high level of accuracy in a 15-year study using that particular periodontal risk calculator. Gum disease, a gum disease risk assessment test is available on the American Academy of Periodontology, AAP website, for patients to use as the risk assessment. And there's also a periodontal risk assessment tool based on tooth loss, genetics, systemic conditions, and periodontal status that can be located on the internet as well, and that's perio-tools.com. Previsor is another one that offices use. It's free for the patient, and they do a periodontal disease risk assessment, oral cancer risk assessment, as well as caries risk assessment, all on the Previsor site. So risk assessments can be used to educate the patient about the level of risk and the factors that can be modified. Some things, as you know, can't be modified: gender, age, that type of thing. But a lot of them can be. So a patient can use the tools to manage their own personal disease risk. The etiology of periodontal disease all starts with the dental biofilm. That's the primary etiological factor. And we've got good bugs and bad bugs in our mouth. And the good bugs are anaerobic as well as gram-positive. The bad bugs are gram-negative. And no, I messed that up. The good bugs are aerobic, gram-positive. I apologize. And the bad bugs are anaerobic, gram-negative. So microorganisms in the form of the biofilm are, again, the primary etiological agents of periodontitis. And the type of organisms shift to the gram-negative anaerobic species that include the P. gingivalis and Tannerella forsythia with the initiation of periodontal disease. So P. gingivalis and the Tannerella forsythia are the bad guys. There's another one called AA, Agrigobacter actinomycocococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococococo aggressive forms of periodontal disease. So AA is another big one. So we've got our P. gingivalis, our Tannerella forsythia, and our AA as the bad guys. Nodal rods and spirochetes are predominant in disease pockets versus healthy subgingival sulci have the aerobic cockeye. So let's go on to talk a little bit more about the risk factors of periodontal diseases. Identification of risk factors can provide insight into assessment and care planning for your individual patient. The various periodontal pathogens don't affect all people the same way in the same degree of severity. It's clear that host factors really play a significant role, how the body can defend itself. But there are modifiable risk factors, and they include tobacco use. If the patient smokes, they can stop. Easier said than done, I know. But evidence provides strong support for the risk of developing periodontal disease and attachment loss as a result of smoking. The odds for developing periodontal disease in people who smoke range from 3 to 7 times higher than those of non-smokers. And more than 40% of the cases of periodontitis are a result from cigarette smoking. So periodontal treatment may be less effective in smokers than those patients who do not smoke. The wound healing is very different also with smokers. Users of smokeless tobacco products experience oral effects including predisposition to oral cancer. Periodontal lesions with severe recession and clinical attachment loss occur where the quid is held, where they hold that smokeless tobacco product. Diabetes is another one. Periodontal disease and diabetes mellitus have a bidirectional relationship, meaning that a patient who does not control blood glucose is more likely to have more severe periodontal disease. So poor control of blood glucose levels increases the risk of developing periodontal disease and results in poor outcomes of treatment. So as a result of the increase in diabetes in the United States population, there is also an increase in prevalence of periodontitis in children as well as adolescents with type 1 diabetes. Research does suggest the management of periodontal infections results in also the management of blood glucose levels. So the more controlled the perio is, the more controlled the blood sugar is. And the more controlled the blood sugar is, the more controlled the perio is. That's the bidirectional aspect of it. There's also psychological factors. Excuse me. Some research suggests individuals under stress are more likely to have clinical attachment loss and alveolar bone loss. Excuse me. Stress itself isn't recognized as an independent risk factor for periodontal disease, but patients undergoing a lot of stress oftentimes alter their self-care habits. Their eating habits change, their brushing and flossing habits change, grooming habits change. Certain medications for specific conditions can lead to gingival enlargement. You'll get more on that when you have your pharmacology course next semester. But enlarged tissue encourages dental biofilm retention. It can complicate removal, so it also increases the potential for periodontal infections. You have phenytoin-induced gingival enlargement, and phenytoin is a drug that's used to control seizures. You can see on figure 19.3 of your textbook. Cyclosporin-induced gingival enlargement, and cyclosporin is an immunosuppressant drug that's used for patients with organ transplants to prevent rejection. Then you have nifedipine, this is why I don't teach pharmacology, induced gingival enlargement, and the nifedipine is a calcium channel blocker that's used in treatment of angina and ventricular arrhythmias. It's a blood pressure medication for the heart. So there are medications that encourage gingival enlargement. There is evidence for the relationship between periodontal health and nutrition, alcohol, as well as socioeconomic status, but more research is really needed to determine whether they are in fact risk factors. So this is just a picture of a standard mouth that has perio. You can see the attachment loss. You can see the loss of interdental papilla. This is a 58-year-old woman, cigarette smoker of 20 pack years with advanced periodontitis. Now we'll talk about pack years. We want to know whenever somebody smokes how much they've smoked and for how long they've smoked. And that gives you your pack years. So this is a long-standing smoker. So you can see that the teeth are discolored due to the nicotine deposits as well, and the oral hygiene is lacking. So we talked a little bit about modifiable risk factors, but there are some non-modifiable risk factors, things that we have no control over. Genetic predisposition, the host response, osteoporosis, as well as other systemic conditions. So, some non-modifiable risk factors. We've got genetic predisposition. From 33 to 39% of the risk for periodontal disease is related to genetic factors. So genetic testing is likely to become more cost-effective and will benefit patients as well as dental providers in targeting those that are at risk for enhanced prevention. We've got host response. Alterations in the immune response may result in periodontal damage as well as an increase in inflammation after a bacterial challenge. Overly active neutrophils or your white blood cells may be responsible for tissue destruction seen in periodontal infections. There's osteoporosis, and there are many risk factors for osteoporosis that are also risk factors for periodontitis, including cigarette smoking, nutritional deficiencies, glucocorticosteroid use, and immune dysfunction. There's a greater alveolar bone loss in patients with osteoporosis than non-osteoporosis patients. There are other systemic conditions also associated with deficiencies with the immune system, like Down syndrome, are also related to increase in periodontal infections. You can have local factors, and although dental biofilm is the primary etiological factor in the development of inflammatory gingival and periodontal diseases, a variety of other factors predispose. Crossbite with limited lateral excursion, unilateral chewing, they're only chewing on one side, food impaction, created by a combined factor of tooth contour, missing proximal contact, proximal carious lesions, irregularly shaped marginal ridge relationships. There is an inclination related to loss of adjacent tooth and plunger cuts from the opposing arch. That means every time the person chews, food is getting packed into or in between two teeth. And that pounding of the food interproximally, time and time again, eventually is going to destroy the periodontal condition between those two teeth. So we want to make sure that we have as few plaque retentive surfaces as possible, and that's something where you will be the detective with when you are doing your soft and hard tissue assessment. You're not only measuring things, but you're looking for discrepancies in the occlusion. You're looking for plunger cuts. You're looking for teeth that are out of alignment and challenges that the patient's going to have. Does the patient, for example, have dental appliances and prosthetic devices? Orthodontic appliances provide retentive areas galore for biofilm. Just that surface area that's being added to the teeth. Fixed partial dentures and deficient margins of abutment teeth or unusually shaped pontics can also be plaque retentive surfaces. Removable partial dentures with inadequate adaptive cusps. Patients don't always take these partials or removable dentures out of their mouth either, so they contain a lot of bacteria on them. Any rough surfaces with teeth or restorations or the contours can also be plaque retentive surfaces. Then we've got our iatrogenic causes. Those are factors created by professionals during treatment. We've got factors such as mastication, saliva, the tongue, the cheeks, the lips, oral habits, and personal biofilm control procedures that also contribute to retention. How effective is the patient in taking care of their teeth? There are dental factors. We have tooth irregularities, the pellicle and biofilm microorganisms attached to defective or rough surfaces, including pits, grooves, and cracks, calculus, exposed, altered cementum with any irregularities, demineralization of any tooth structure, iatrogenic factors such as rough or grooved surfaces left after scaling or inadequately contoured and polished dental restorations. We also have tooth contour. The altered shape may interfere with what the patient's able to clean. There could be congenital abnormalities, extra or missing cusps or bell-shaped crowns that make it more difficult for the patient to clean. And teeth that are flattened proximally or have faulty contacts with adjacent teeth that permit food to actually get wedged between the teeth is a constant problem, especially if the food is not being cleaned out. We've got occlusal and incisal surfaces that are altered by attrition, wearing down, that interrupt normal excursion of the food during chewing. The food can't move to where it needs to go in the mouth. There's areas of erosion and abrasion, carious lesions, heavy calculus deposit, and biofilm always is retained on top of that surface. There's over-contoured, under-contoured, overhanging restorations. You've got pictures of those in your book. Tooth position, malposition, can irregularly alignment of a single tooth or groups of teeth. We saw that when we were talking about biofilm, crowded, rotated, overlapping teeth, deep anterior overbite, mandibular teeth that force food particles against the maxillary lingual surface. There's lingual inclination of the mandibular teeth that allow the maxillary teeth to force the food particles against the mandibular facial gingiva. You've got tooth adjacent to edentulous areas that may be inclined to migrate. You have opposing tooth missing. The tooth doesn't have any detersive action, and it may actually extrude beyond the line of occlusion. Then you've also got other factors related to eruption. Incomplete eruption, where the teeth don't erupt into the line of occlusion, partially erupted or impacted third molars, the lack of function, or the use of teeth actually eliminates or decreases the effectiveness of natural cleaning, lack of opposing teeth, and also there's a picture of an open bite. You know, the teeth just don't contact. You can have marked maxillary anterior protrusion, crossbites, unilateral chewing. Some patients only have 2 teeth that are touching that they chew with. Food impaction created by the combined effect of tooth contour, missing proximal contacts, carious lesions, and other things like that, as well as defective contact areas from faulty margins, irregular margins, as well as dental appliances. We have gingival factors. Position, size and contour, and the effects of mouth breathing. And that's something that the previous edition didn't touch on. The position, the deviations from normal provide retentive areas for biofilm. If the gingiva is receded, its depressed area is left at the CEJ junction. Okay, you've got that area exposed. If the gingiva is enlarged, it's extended to or over the height of contour. The reduced height of the interdental papilla leaves open interdental areas, more surface area for biofilm. There could be a tissue flap over the occlusal surface of erupting teeth, and when it happens over a third molar, it's called the operculum, that flap. You get a periodontal pocket, and the shape of the pocket might be conducive to biofilm collection, and the depth of the pocket might not be accessible for toothbrushing or other aids for the patient to be able to do self-care with. Calculus also provides a rough retentive surface for more biofilm. Then we've got other factors, and a variety of factors can predispose or contribute to the progression of periodontal infections. Some of the items that we're going to talk about may have more of an indirect effect, and others have more of a direct effect on the oral tissues. So we've got personal oral self-care and diet and eating habits. Personal oral self-care, the biggest one is neglect. This can lead to generalized dental biofilm accumulation and disease promotion. Faulty biofilm control, which is incorrect use of the toothbrush using an abrasive dentifrice that's too harsh for the patient, so they're eroding and abrading the gingiva and their teeth, and the effects of other harmful or detrimental procedures that we're going to get into in another chapter. So even though the patient's brushing 3-5 times a day, if they're not doing an effective job, they're still leaving biofilm behind. So part of it is being aware of oral self-cleanliness, and the cleansing habits include both self-cleansing mechanisms and mechanical biofilm removal, and they depend in part on an individual's perception and feeling of debris through the taste and tongue activity. Some patients don't feel the fuzz on their teeth, others do. So through our education with the patient and using disclosing solutions so they can see what's on their teeth, we can hopefully help increase their education and awareness of what they're doing and what they need to be doing. So awareness is key. Then diet and eating habits, we talked a little bit about also already. Soft foods, though, tend to adhere more than fibrous, firm foods, and there's keriogenic food selections. Remember, we were talking about the pH in another chapter. There's masticatory deficiencies that limit diet selection. So if the patient's missing teeth, or they only have their anterior teeth to chew with, they're going to be on a much softer diet than somebody who has all of their teeth. And other foods are more keriogenic also. We used to think, that raisins, even though it's a fruit, is much more highly keriogenic than chocolate because the pieces of raisin are going to get stuck in the pits and fissures and stay there. There's a little bit of discrepancy right now on that one, but that is still the thought, that if it's going to be sticky in your teeth and stay in your teeth, it's going to be more keriogenic than something that can be washed away. So this is periodontal disease chapter. So let's talk a little bit about the pathogenesis of periodontal diseases. And we have an acute inflammatory response. And pathogenesis, I'm not being able to talk today. Pathogenesis refers to the process by which a disease develops and progresses. So the primary etiology of periodontal disease we know is bacteria that is initiated into an inflammatory process. And the inflammatory process is a very complex situation, and it's influenced by the patient as well as environmental factors. So we have an acute inflammatory response. So when the immune response is working effectively, the presence of biofilm results in gingival inflammation with no breakdown of tissues. There's an activation of a local acute inflammatory response that begins the process of lesion development. And the stages of development of gingivitis and periodontitis are divided into the initial lesion, early lesion, established lesion, and advanced lesion. And yes, you need to know these. So with the accumulation of dental biofilm on the cervical area of the tooth surface adjacent to the gingival margin, an inflammatory reaction is initiated and the immune system responds. So then we've got the initial lesion. And the inflammatory response to dental biofilm occurs within 2 to 4 days in response to bacterial accumulation. You have migration and infiltration of white blood cells into the junctional epithelium and the gingival sulcus that results from the natural body's response to infectious agents. There is an increased flow of gingival crevicular fluid. There's early breakdown of collagen of the supporting gingival fibers, and we'll get into more of that in chapter 18. Fluid fills the spaces in the connective tissue. For the clinical appearance, there's no clinical evidence that appears in the earliest phases here. There's slight marginal redness with enlargement due to fluid collection that might be seen. Then we've got the early lesion, and that's the increased inflammatory response. So dental biofilm becomes older and thicker, 7 to 14 days, depending on individual differences. Infiltration of fluid, lymphocytes, and neutrophils with the plasma cells go into the connective tissue. There is breakdown of collagen fiber support to the gingival margin. You have epithelium proliferating, epithelial extensions and ready ridges are formed. So clinically, the early signs of gingivitis become apparent with slight gingival enlargement, which will become an established lesion if undisturbed. Early gingivitis is reversible when biofilm is controlled and the inflammation is reduced. So healthy tissue can still be restored. Susceptibility of individual varies, and the time before the lesion becomes established varies as well. So we go from the early lesion now to the established lesion. You've got fluid and leukocytes migrating into tissues and sulcus that continues. The plasma cells are related to areas of chronic inflammation. You now have pocket epithelium. You've got proliferation of the junctional and sulcular epithelium, an attempt to wall off the inflammation. The pocket epithelium is more permeable. Areas of ulceration of the lining of the epithelium develop. Early pocket formation with bleeding on probing is evident. You've got collagen destruction that continues and connective tissue fiber support is lost. Progression to early periodontal lesions may occur, or the established lesion may remain stable for an extended period of time. Again, it all depends on the host. Clinical appearance, clear evidence of inflammation is present with marginal redness, bleeding on probing, and marginal gingiva that's very spongy. Then later, you have more chronic fibrosis develop, thick, leathery tissue, and that's really evident in smokers. So again, if the established lesion is not controlled, it then eventually will move on to the advanced lesion. And that's an extension of inflammation. So the bacteria from the supragingival biofilm enter the sulcus and provide the source for subgingival biofilm. Biofilm microorganisms produce irritants. You've got alveolar bone destruction that results from the host immune response to the bacteria, causing a cascade of events to stimulate osteoclastic activity. There's progressive destruction of connective tissue. Connective tissue fibers below the junctional epithelium are destroyed, and the epithelium migrates along the root surface. So you've got that apical migration. The coronal portion of the junctional epithelium becomes detached. The coronal portion of the junctional epithelium becomes detached. Exposed cementum, where the sharpest fibers used to attach, become altered by the host response to the bacterial challenge. You have diseased cementum that contains a thin superficial layer of endotoxins from the bacterial breakdown. And that's where we used to want to remove all of that diseased cementum and get that glass-like structure now. And now we're using things with glycine. It's the air powder polisher. We're using it subgingival with a non-abrasive glycine product to help detoxify those root surfaces. Pocket formation occurs. Mobility, bone loss are all signs of periodontitis. Persistence to the chronic inflammatory process occurs. You've got plasma cells predominating. The junctional epithelium continues to migrate apically. The lesion extends through the connective tissue. And even with the advanced lesion, there are periods of inactivity as well. So they could stay at that level for quite a long time. And what's the difference between a gingival and a periodontal pocket and a pseudopocket? Okay, so it is the presence or absence of infection that really distinguishes a pocket from a sulcus, and the level of attachment on the tooth that distinguishes a gingival pocket from a periodontal pocket. So a pocket has an inner wall, which is the tooth surface, and an outer wall, which is the sulcular epithelium or pocket epithelium of the free gingiva. And the two walls meet at the base of the pocket. Are you all visualizing that? So the base of the pocket is the coronal margin of the attached periodontal tissues. Histologically, the base of a healthy sulcus is the coronal border of the junctional epithelium, whereas the base of the pocket in the diseased sulcus may be at the coronal border of the connective tissue attachment. I'm going to repeat that. Histologically, the base of a healthy sulcus is the coronal border of the junctional epithelium versus the base of a diseased pocket may be at the coronal border of the connective tissue attachment. Substances found in a pocket. Communication of the opening of the pocket with the oral cavity really provides the opportunity for dental biofilm to collect. And the deeper the pocket, the more difficult it is to clean by toothbrushing as well as other biofilm control devices. It's even more difficult for us to get to. So we've got microorganisms and their products found in the pocket. Enzymes, endotoxins, and other metabolic products. You've got your gingival crevicular fluid. You have your desquamated or dead epithelial cells. You've got leukocytes, and the numbers increased with the incidence of inflammation in the tissues. You've got purulent exudate, made up of living and broken down leukocytes, living and dead microorganisms, and serum, purulent, that's pus. Pockets are divided into gingival and periodontal types to clarify the degree of anatomic involvement. The periodontal pockets are further categorized by their position in relation to the alveolar bone. So that's whether the pocket is at the base is suprabony or intrabony. So a gingival pocket or pseudopocket, by definition, is a pocket formed by gingival enlargement without any apical migration of the junctional epithelium. So that is gingivitis. So the margin of the gingiva has moved toward the incisal or occlusal without any deepening of the periodontal structures being involved. So the tooth wall of the pocket is the enamel, and during eruption, the base of the sulcus is at various levels along that enamel, and the base of the sulcus on a fully erupted tooth is near the CEJ. So all gingival pockets are suprabony. That is, the base of the pocket is coronal to the crest of the alveolar bone. Versus periodontal pocket, by definition, is the pocket is formed as a result of disease or degeneration causing apical migration of the junctional epithelium along the cementum. So you have apical migration of that junctional epithelium. The periodontal deeper structures of the attachment apparatus are involved. So that's the cementum, periodontal ligaments, as well as the bone. The tooth wall of the pocket is cementum. Unlike the gingival pocket, it is enamel, or partially cementum and partially enamel, right, for the periodontal pocket. The base of the pocket is on the cementum at the level of attached periodontal tissues. So a periodontal pocket can be suprabony or intrabony. So a suprabony pocket is a pocket in which the base of the pocket is coronal to the crest of the alveolar bone. So if you look in the textbook, figure 19.8, A, B, and C, and that's going to be on our next slide. So let me get that up here. All right, so you've got your normal pocket in A. Okay, the junctional epithelium is right at the CEJ. The gingival pocket, the junctional epithelium is at the CEJ, but the tissue is up higher because of the inflammation. Then you've got your periodontal pocket, which is suprabony in C, and your intrabony, which is D. So an intrabony pocket is one in which the base of the pocket is below or apical to the crest of the alveolar bone. And so the alveolar bone is here, and the base of the pocket is there. So that's an intrabony pocket. Intra means located within bone. The term infra is used in some texts also. So intrabony and infrabony mean the same thing. So in our Perio book, next semester in DNH 146, we are going to call it infrabony. Infrabony, intrabony mean the same thing. So you've got tooth irregularities. Also, to consider, supragingival tooth surface irregularities are detected by drawing the tooth surface and actually using vision as well as an explorer. Subgingival examination is dependent for the most part on tactile and auditory sensitivity transmitted through the probe and the explorer. Some causes of surface roughness on the enamel surface can be structural defects, cracks or grooves, demineralization, calculus deposits, heavy stain deposits, erosion, and certain types of irregularities. There could also be root surface irregularities, diseased or altered cementum, cemental resorption, root caries, abrasion, calculus again, deficient overhanging restorations, which is shown in figure 19.5, certain grooves and irregularities. So the relationships of enamel and cementum at the CEJ are also shown in chapter 18. So this isn't going to be the only time you hear about this. Some complications resulting from periodontal disease progression are furcation involvement and mucogingival involvement. So furcation involvement means that the clinical attachment level and bone loss has extended into the furcation area between the roots of multi-rooted teeth, and we use the Glickman furcation grades. The presence of furcation involvement increases the risk of periodontal tooth loss. And it's difficult to adequately remove all the biofilm and calculus from the furcation area. For the patient to keep clean, for us to keep clean. So if the patient has any furcation areas, they are automatically put into a poor prognosis for their periodontal disease risk assessment. And we're going to have a slide in a couple more slides to show you the Glickman classifications. But you're going to be doing clinical observation. So when the gingiva is over the furcation and it's not receded, you can't see it. So the furcation is covered by the pocket wall. And oftentimes there's no difference in color, size, or other tissue changes to really let you know that there's something going on there. So there could be a radiolucency in the furcation area that's noted on the radiograph. But when the gingiva is over a molar furcation area and it's receded, the root division can be seen directly. And that is a grade 4. You can see it. You can clean it. The patient can clean it. So a suggested procedure for probing furcations is described in chapter 20, but we're going to get into that also in clinic. So then the other complication is a mucogingival involvement, and we've seen that in oral anatomy as well in that class. But a pocket that extends to or beyond the mucogingival junction or into the alveolar mucosa is mucogingival involvement. There's no attached gingiva in that area, and the probe can pass through the pocket if you press hard enough and beyond that mucogingival junction into the alveolar mucosa. So we like seeing a nice thick zone of attachment whenever it's possible. The functions of the attached gingiva are great. It gives support to the marginal gingiva. It helps withstand the frictional stresses of chewing and toothbrushing. It provides attachment or a solid base for the movable alveolar mucosa, like our lips and our cheeks. It acts as a barrier to the passage of inflammation. That junctional epithelium, where the epithelial attachment acts as a barrier to keep infection outside the body. And with destruction of the connective tissue and periodontal ligament fibers under the junctional epithelium, the epithelium migrates along the root surface. And in mucogingival involvement, the bottom of the pocket extends into the alveolar mucosa. So it's unconfined inflammation can spread more rapidly through that loose connective tissue. So we want to look for clinical changes. Color changes, we're doing a tension test, we're pulling the lip and the cheeks to see if that frenum is actually tugging on that tissue. The movable tissue is also something that you're using with your probe to detect where that free gingiva is as composed to the attached gingiva. You're measuring the attached gingiva. That's a narrow zone of gingiva from the gingival margin to the mucogingival junction is more susceptible to developing mucogingival involvement because there's less attachment to begin with. We want to look and see where the base of the pocket is in relation to the mucogingival junction. So when the attached gingiva measures 1 to 2 millimeters and there's no bleeding on probing or the marginal inflammation, it's recorded and evaluated at each continuing care or periodontal maintenance appointment. Long-term longitudinal studies have shown that in the absence of inflammation, areas of narrow bands of attached gingiva can be maintained for long periods of time. The patient just doesn't have a lot of flexibility, so you need to be for getting recession or inflammation in those areas. So you need to really monitor those areas closely. And sometimes they require specific instruction in biofilm control procedures. So when an area has minimal attached gingiva, like 1 to 2 millimeters, and is placed under stress by restorative, prosthetic, or orthodontic treatment procedures, the patient should be referred to a periodontist for evaluation for the need of gingival or connective tissue grafting to put surgically attached gingiva there. Mucogingival deformities and conditions are included in the 1999 classification of gingival and periodontal diseases and conditions, and that's on table 19.1. And that's included in the diagnosis. So this is showing you the different classifications of furcations. Class 1 furcation here, you can just get the explorer, the probe, into the crotch of the tooth. Class 2, you can get it into the crotch of the tooth, but it doesn't go all the way through. Class 3, or grade 3, you can get it all the way through from one side to the other side, but it's covered with gingiva. And then the grade 4 is the gingival margin is apical to the furcation, so there is exposed areas in the oral cavity. And sometimes the dentist or periodontist will surgically create that recession so a proxa brush can actually go through. And we've seen this picture before of a mucogingival defect. So this is the recession. This is the CEJ right there. You measure from the CEJ to where the attachment is, and you subtract. The recession. So when you take a look at this bottom picture here, whether you're doing the math or not, you can, if you can see that probe right at the base of that sulcus, that is a mucogingival defect. So you're doing math with the computer, but you're also verifying with your probe. So the width of the keratinized gingiva is measured, say, 2 millimeters. The probe depth is measured at less than 2 millimeters. It's 1 millimeter probing, indicating no mucogingival defect. But if the probe depth reached or exceeded that mucogingival junction, if it probed 2 millimeters, and if you were 2 millimeters from here to here, and then you probed 2 millimeters, that's a mucogingival defect. So again, you're doing a little bit of math. Calculus can form in furcation areas, and if there was gum tissue there, it would be impossible, as you can see, to reach. Another mucogingival defect, number 24, the narrow zone of attachment. Right there, you need to get the probe in to see where that probe falls. The patient really needs to be motivated to take care of their teeth. So we are the fact finders. And we're the ones doing the clinical examination. And the recognition of normal gingiva, gingival infections, and deeper periodontal involvement really depends on a systematic step-by-step examination. So it's necessary to know the extent of the disease. Gingival infections are confined to the gingiva versus periodontal infections include all parts of the periodontium, namely the gingiva, periodontal ligament, bone, and cementum. A basic examination performed to recognize the signs and effects of inflammation includes information about certain markers. You're looking at the gingival tissue, color, contour, shape, texture, position. You're looking for mucogingival involvement. Is there an adequate width of attached gingiva? You're looking at probing depth, bleeding and exudate, furcation involvement, dental biofilm and calculus that's present. You're checking for mobility. You're also doing a radiographic interpretation. The signs and symptoms of periodontal disease. The patient may or may not have any specific symptoms or report anything because periodontal infections are insidious and slow to develop oftentimes. Symptoms the patient may notice or feel could include bleeding of the gingiva when they brush, bleeding with drooling at night. They wake up with blood on their pillow. On occasion, spontaneous bleeding of the gingiva. Other symptoms the patient may notice could be sensitivity to hot and cold, tenderness or discomfort while eating or pain after eating, food retained between teeth, unpleasant mouth odors, chronic bad taste in their mouth, and just the feeling that their teeth are loose. Most of these symptoms are of the more advanced lesions also. So you're looking at the mouth and you're trying to find changes in tissue. Disease changes produce alterations in the color, size, position, shape, consistency, surface texture, bleeding readiness. Do they bleed on probing easily, or do you have to poke really hard to get any bleeding, as well as exudate production. So to understand the changes that take place in the gingival tissues during the transition from health to disease, you really have to understand the role of biofilm in the development of the disease. You need to understand the inflammatory response that's initiated by the body. And when the products of the biofilm microorganisms cause breakdown of the intercellular substances of the cellular epithelium, you've got injurious agents that pass into the connective tissue where the inflammatory response is initiating. An inflammatory response means that there's an increase in blood flow, increased permeability of the capillaries of the connective tissue, and increased collection of defense cells, your white blood cells, your neutrophils, and tissue fluid. So changes produce the tissue alterations, such as color, size, shape, consistency, okay, that we're going to talk about. So the severity and distribution of change in the gingiva can be noted during your examination. When a deviation from normal affects a single area, it can be designated by adjacent to certain teeth or by the surface of the tissue involved, namely the facial, the lingual, the mesial, or the distal. And you want to be as specific as possible. So we've got more descriptive terminology. You have generalized, marginal, papillary, diffuse, for example. Generalized means the gingiva is involved about all or nearly all of the teeth throughout the mouth. It's going to be over 30% of the teeth involved is generalized. Otherwise, it's considered localized. Marginal affects the change that is confined to the pre or marginal gingiva, and that can be either localized or generalized. Papillary is a change that involves the papilla but not the rest of the pre-gingiva. Papillary can be localized or generalized as well. Diffuse means spread out or dispersed. It affects the gingival margin, attached gingiva, and the papilla, and may extend throughout the mouth. So you want to be as specific as possible when you're making your description. So we've got our generalized, localized, marginal, papillary, diffuse, and we're going to have severity. Severity is expressed according to the quantity of clinical attachment loss. So we've got slight or mild, which is 1 to 2 millimeters of clinical attachment loss, moderate 3 to 4 millimeters, and severe or advanced 5 millimeters or greater. So if it's slight or mild, you've got 1 to 2 millimeters of clinical attachment loss, moderate 3 to 4, severe or advanced 5 or more. With the severity, you have distribution or extent. So you need to know if it's localized, involving less than 30% of the teeth, or generalized, more than 30%. Generalized, when you're talking periodontal infection, you are talking about specific words. The AAP, American Academy of Periodontology, has their periodontal disease classification. And you start with generalized or localized. Then you go to extent. Is it slight, moderate, or advanced? Then you list what it is. Gingivitis, chronic, periodontitis, acute, whatever. So there's very particular way that you are going to be labeling what you're finding in your patient's mouth. And we're going to go over that, so don't get too worried about that. But we need to have early recognition of tissue changes. Marked changes, such as moderate to severe generalized redness, enlargement, sponginess, deep pockets, those type of things, are relatively easy to detect, even with a novice student. But in contrast, when the changes are subtle and localized, about 1 to 2 teeth, and to a lesser degree of severity, it really takes a more mindful, skillful application of knowledge. And that's what we are here to help train you to see. When you're doing a gingival description and you're saying it's coral pink, knife-edged, tightly adapted, stippled, that's giving me all the signs of health. And then we're looking to say, okay, it's generalized that, but can you see this over here? Can you look at this papilla? Look at this margin. We want you to zero in on those type of areas as well. Risk assessments, along with early recognition and treatment of gingival and periodontal infections, can result in the prevention of disease progression and the need for more complex surgical treatment. And hopefully the response to non-surgical periodontal treatment is more predictable the earlier we catch something. So the patient history, their risk assessment, the clinical exam that you do, the radiographs, and other data from the assessment are all put together to determine the initial diagnosis, which range from gingivitis or health to advanced periodontitis. So except in cases of advanced periodontitis, the need for additional treatment after non-surgical periodontal therapy, which is what we do, is really difficult to predict. So we've got reevaluation following our non-surgical periodontal therapy. It's really built into the care plan. We bring them back 4 to 6 weeks after we're done to do another periodontal evaluation for them and see how they're healing. But on tables 19.1 and 19.2 is the classification of gingival and periodontal diseases. So just review that. You're not going to need to know them verbatim. We have a whole course on that next semester. But they are good cheat sheets to have, clinic help sheets to print out for your clinic notebook. And they are in the clinic help section as well. Good thing is now since we've gone paperless, there are also guides built into the templates that you're going to be using. So the key thing here is we do a thorough workup with our patients, and we have to document. And documentation for a patient with need for periodontal therapy includes at least the following in the patient's permanent record, along with the radiographs and physician's approvals if we need them. but the initially complete history, medical, dental, any former periodontal therapy that they might have had, current symptoms, current complaints or chief complaints, the clinical examination with charting, with periodontal findings and of the teeth, so that's soft and hard tissue, summary of prognosis as well as diagnosis. And at each appointment, a complete record of treatment is accomplished in patient instructions, oral findings, and changes that we may be finding. So it's really important that we teach the patient the connection between periodontal disease and systemic disease as it's related to their patient history. There are different risk factors that we will be able to identify and help the patient modify. You need to know also, explain to the patient the difference between normal versus disease. And not just in theory, but if you can show it in their mouth, look how pink this is versus look how purple and swollen this is over here. This is disease, this is health, this is what we want. We need to also teach the patient the need for a comprehensive periodontal examination. They don't like it, it takes time, doesn't always feel good, they just want to get their teeth cleaned. But again, we need to explain to them why we're doing it. And we need to explain to them the need for adequate oral self-care and continuing care. They need to keep coming back in order to help manage their infections. So that is periodontal disease development. It's a pretty heavy chapter. There's a lot of learning that you have to do, but you'll get through it. And the nice thing is, after this chapter, that makes DNH 146 that much easier. So that's it for Chapter 19.